هنعمل جايد لاينز سيريس اوف ليكتشرز على كل الاي دي اس اي جايد لاينز، ودي اولهم باقتراح هيكون الفاضل الدكتور مصطفى. انا هحاول اكون in most of my slides committed للاي دي اس جايد لاينز. في بعض الحاجات اللي هقولها هقول these is not on guide lines عشان يبقى ايه ادينا الجايد لاينز حقها وما ضفناش حاجه على الجايد لاينز اللي هي اصلا ما شاء الله very satisfactory when you compare it to the other guidelines هنتكلم عنها. النهارده موضوعنا هنتكلم عن Clostridioides difficile او اللي زمان كنا بنسميها Clostridium difficile colitis IDSA and more. هنتكلم في ايه النهارده على في محاضرتنا النهارده؟ هنتكلم على الاورجانيزم itself، البروبرتيز اوف اورجانيزم، هنتكلم على changing epidemiology ايه اللي حصل، هل ايه الهايبر فيرالنت سترين اللي موجود، وهل بنعمل له تيستنج ولا لا، وفي تيستنج في مصر الهايبر فيرالنت سترين ولا لا. هنتكلم على الكلينيكال بيكتشر، الدايجنوزس، التريتمنت، الانفكشن كنترول. الناس اللي بتاع الانترست في الانفكشن كنترول هتلاقي جزء مهم قوي في الانفكشن كنترول وهاو تو ريبورت. الكلام ده very very important and very serious. طيب لما نتكلم في الاول على الاورجانيزم والابيديميك سترين كابيديميك سترين، اول حاجه هنقولها هنتكلم عليها في الاول الريكلاسيفيكيشن. زمان التسميه كانت كلها كوليستريديوم ديفيسيل، اتغير الاسم الى كولسترويدز ديفيسيل، ودي ريسنتلي الكلام ده من حوالي 5 years بس. ودي في ديتيلز كتيره مش هنخش فيها عشان ما ندخلكمش في ايه في حاجات جانبيه، بس ان شورت السي ديفيسيل از جرام بوزيتيف اورجانيزم انيروبيك، ودي مشكله كبيره بالنسبه للمعامل وهنعرف ازاي واهميته الكلام ده ايه. سبور فورمينج وهنقول ايه اهميه السبورز. vegetative cells بتداي في الايروبيك انفايرمنت، also بتداي في الستومك، عشان كده اللي بيعدي من الستومك هي السبورز اكتر من الفيجيتيف فورم. السبورز can survive and live for very long time in the environment. طيب ايه الامبورتنس في ستورز؟ ليه اهميتها ايه؟ It resistant to heat ودراينج والبريشر even many disinfectants. السبورز are not reproductive form. بعد كده بيبقى في حاجه اسمها الفيجيتيف فورم زي ما هنشوف في الباثوجينيسيس. طب ايه الريسك فاكتورز فور انفكشن؟ Who will develop the C. difficile colitis? Any hospitalized patient, hospitalization especially long term care facilities. الانتيبيوتكس، use of antibiotics، وهنتكلم على الانتيبيوتكس in details ايه اللي هي الموست كومن وايه الليست كومن antibiotics to cause C. difficile. Age more than 65 is very vulnerable to complications also. Comorbidities like CRF, diabetes, HIV, chemotherapy, abdominal surgery. What about the PPI? ال IDSA قالت ايه على الجايد لاينز to stop or not to stop. الكلام ده very serious and very important. في studies كانت بتقول ال PPI one of the predisposing factor للسي ديفيسيل، بس هنوقف ولا لا هنتكلم في المانجمنت بعد كده. community associated cases في association مع البيريبارتم close contact مع السي ديفيسيل case او some foods. طيب لما نتكلم بعد كده على نري الوكيت اللي قلناه بالنسبه للموضوع ال predisposing factors، again في host factors، في organism factor، في environmental factors، والثلاثه دول بيؤدوا الى السيفير ديزيز اللي هنتكلم عنه زي ما هنشوف حالا دلوقتي. المشكله مش في الكميات كيسز بتاع السي ديفيسيل. السي ديفيسيل كيسز دي tip of iceberg. Only 1/3 of cases had present befrank disease of C. difficile colitis or infection. The problem is the asymptomatic carriers اللي هنشوفها، وهنشوف الاطفال نفسهم less than 1 year of age بيكونوا كارير قد ايه، والادلتس بيكون فيهم كارير قد ايه. sometimes it can reach to 70% of cases as carriers. طب ايه الانتيبيوتكس؟ وات ار ذا انتيبيوتكس؟ قسموهم، والتقسيمه دي موجوده everywhere في الاب تو ديت وفي غيره، على frequently associated antibiotics بالسي ديفيسيل، occasionally associated وريرلي associated. الفريكوينتلي قالوا الفلوروكوينيلون، كليندا اند كيفالوسبورين، دول most common 3 antibiotics to be associated مع السي ديفيسيل. بعدهم الكاربابينونز والبنسلين، occasional الماكرولايدز والبنسلين، السلفونامايدز، الريرلي associated الامينو جلايكوزايز، التتراسايكلين، التايجي سايكلين. عشان كده لو في بيشنت وهيستخدم انتيبيوتكس وكان عنده ديزيز ممكن يستخدم التتراسايكلين، ده ليست one of the least. even the metronidazole and vanco اللي بنستخدمهم في treatment of C. difficile colitis rarely associated with C. difficile colitis. طب ايه يعني how big the problem? What is the severity of problem? more than 500,000 cases in the states annually having C. difficile colitis in the states. 60% hospital acquired والباقي community acquired. وهنقول الثلاث تقسيمات اللي بنقسمهم للحالات. طيب قد ايه منهم mortality؟ almost 30% mortality per year في الستيتس من السي difficile colitis. مش كده وبس، في incidence of difficile infection in patients with inflammatory bowel disease. دول big important group of patients بيحصل لهم سي difficile colitis. عشان كده هنشوف حالا دلوقتي الامريكان جاسترو اسوسيشن for recommendations for patients with the flare of inflammatory bowel disease, you should do C. difficile toxin to see what's going on. طب how the disease is pathogenic, how the C. difficile organism will cause the colitis and cause this severe disease up to mortality. It produces two most important toxin and one less important toxin. Two toxigenic strains produce two large protein exotoxin. This exotoxin, one of them enterotoxin, we'll see how it causes the disease, toxin A, and cytotoxin, it directly affects the intestinal mucosal cells. And the some mutant strains do not produce toxin A or B. And some strains make the third another toxin, which is called binary toxin. By itself is not pathogenic, but it acts synergistically with toxin A and B to produce the disease. هنشوف أهميته إيه حتى الباينري توكسين ده في حالات الهايبر فيرالنت سترين. And so for a Clostridium difficile organism to cause a disease, step number one, the organism will have the ingestion of the spores. After ingestion of the spores, it passes through the stomach. The spores will not be affected by acidity. It goes to the intestine. And then step two, there is germination of these spores into vegetative form. After germination, there is altered intestinal flora by use of antibiotics. So the C. difficile will start to flourish and producing toxin A and toxin B. And we'll see how pathogenic this toxin A and B and producing these pseudomembranes, the one will be seen right now. These are the pseudomembranes in colonoscopic picture with characteristic pattern, and this is one of the diagnostic criteria according to the IDSA. Another picture of the pseudomembranes also. This is the, again, it starts by small batches like this and then start to coalesce to form a pseudomembrane like what you are seeing now. And this is the pathology of the intestinal mucosa. Colonic mucosa is raised, yellow batches. These small batches will coalesce and enlarge and forming this pseudomembrane. How toxin A will cause the problem for these patients? It binds to specific receptors on the intestinal epithelium. After binding to this receptor, it attracts the neutrophil and the inflammatory mediators. It causes fluid secretion, altered membrane permeability, and causing hemorrhagic necrosis. This is the toxin A. What about toxin B? Toxin B is directly cytotoxic, directly. It binds to certain receptor, but not identified till now what receptor for toxin B. It depolarizes the filamentous actin in the mucosal cells, lead to destruction of the cell cytoskeleton and the rounding of the cells and start to have cell apoptosis and cell death. This is regarding toxin A and B. If the patient having this C. difficile exposure with antimicrobials will have either one of two fates. It will be either asymptomatic colonized or having C. difficile infection. What is the epidemic strain? All the guidelines, even the last guidelines talking about epidemic strain. It's called B1/NAB1 027. This is what NAB1, North American pulse field type 1. Ribotype 027. This 027 is done nowadays even في المستشفى 57. They are doing this by gene expert detecting the hypervirulent strains. What is the importance of this strain? It causes both increased development of hospital endemic acquired foci and increased incidence. Why it's called hypervirulent? Hypervirulent, it forms more spores, highly resistant to fluoroquinolones, and produces very high amount of toxin. A and toxin B. The strain is called again NAB1/27. It produces again toxin A and B and binary toxin even, which is synergistic to both toxins. How does it produce that huge amount of toxin A and B? There is the regulating gene or negative regulator. This gene is negative regulator in front of you, the small one with X. This gene will be deleted. If it is present regularly in any bacteria of C. difficile, less amount of toxin A and B are produced. This gene in that epidemic strain are deleted. So huge amount of toxin A and toxin B are produced, which will appear in the next slide. This is the toxin NAB1, and this is the non-toxigenic strain showing toxin A production, huge amount of toxin A and toxin B. And now we know already what is the bacteria, we know the incidence, what is the clinical presentation, and what's the definition from the IDSA of the definite case of C. difficile. We'll have a spectrum of either asymptomatic colonized, 10 to 60% of infants under 1 year are sometimes colonized with this one, C. difficile. 3% of healthy adults can be colonized asymptomatic, which should not be treated. And 10 to 20% of hospitalized patients will be colonized and asymptomatically colonized with the disease. The most important presentation is watery diarrhea. It is the most common presentation. At least 3 attacks of diarrhea in 1 day to suspect in a hospital. Associated with lower abdominal pain, cramping abdominal pain, low-grade fever in 15%, sometimes leukocytosis, but less than 15,000, and we'll see why less than 15,000 in the mild cases. What about the severe and fulminant colitis? They defined the severe case in the last IDSA guidelines of having patients with symptoms, abdominal pain, diarrhea, and dehydration, or whatever, plus leukocytosis, more than 15,000, plus creatinine, which is defined in these guidelines to more than 1.5 milligram per deciliter. It was not defined before. Fulminant defined fulminant C. difficile colitis. Fulminant C. difficile colitis, the C. difficile colitis requiring ICU admission because of hypotension, intestinal perforation, and toxic megacolon. We'll see how it appears, the toxic megacolon. We should and the C. difficile colitis fulminant case may present as acute abdomen or small and colonic distension, sometimes little or no diarrhea because of ileus. And the patient with ileus will have, as we'll see later, special type of management. Sigmoidoscopy sometimes diagnostic. And we should know this by heart. What is the toxic megacolon? This rule of 369. Small bowel normally should be less than 3 centimeters. Large bowel should be less than 6 centimeters. Cecum should be less than 9 centimeters. If higher than this, if you find the transverse colon of 9 or 10, this is toxic megacolon in a patient with C. difficile. What are the indicators that this patient is going to a bad prognosis? Bad prognosis, patient presenting with severe hypotension necessitating vasopressor, high fever more than 38.5, ileus, peritonitis, rebound tenderness, mental status change, WBC is more than 20,000, lactic acid with lactic acidosis more than 2.5, admission to intensive care, end organ failure, and failure to improve after 3 to 5 days. This is bad prognosis and should be taken care of these cases very well. The case definition for Clostridium difficile infection, more than 3 unformed stools. You should not do the lab having even in في مستشفى 57 57 hospital, there is criteria to accept a sample. Many times in the hospital I am working now, the lab is rejecting the samples because the hardest tools are sent to the lab to check for C. difficile toxin. No, case definition, more than 3 unformed stools in 24-hour period, plus positive stool toxin. This is case definition, or even colonoscopic or histopathologic finding compatible with pseudomembranous colitis can be also one of the diagnostic case definition criteria. If there is recurrence of this C. difficile colitis, yes, sometimes the recurrence is very high. Recurrence definition, reappearance of symptoms after treatment has been discontinued. More than 30% experience recurrence within 30 days of treatment. We should differentiate sometimes. This is recurrent symptom can be either to do relapse of the original infection or reinfection by a new strain. This is a very important slide showing that after the initial episode of Clostridioides difficile colitis, you can have relapse 25%. After the first recurrence, 40% relapse. After the second recurrence, up to 50% incidence of relapse. And now we know already what is the organism, we know the pathogenesis, we know how the patient will present, what is the lab diagnosis, and what's available in Egypt to help us in the diagnosis. Number one, the character of the specimen. This should be known by the treating physician and the lab on the same time. There's no, number one, the sample should be liquid and loose, not solid sample. This is number one, fresh. What means fresh? Less than 2 hours. If you are sending the sample more than 2 hours, you should refrigerate at least 4 degrees centigrade. In a refrigerator, regular refrigerator, up to 3 days. If more than 3 days, you will test the samples, you should freeze it at least -70 if more delayed than this one. Specimen quality is very, very important by the IDSA to say this is sensitive sample. We'll classify the lab diagnosis into 2 big categories, either toxin testing or tests directed to the organism itself. To the toxin, we have the ELISA available everywhere in the world, in Saudi Arabia and in Egypt. Immunoassay, ELISA for toxin. It is less sensitive than the NATS or molecular technology. It is less sensitive and little bit more specific. What is the advantage of this ELISA toxin A and B? It's easy to test, cheap, quick. Turnaround time is very rapid. You can do it in 3 hours. It's very easy job. This cell cytotoxicity, they are getting the toxin and putting it in a membrane of cells to see the cell cytotoxicity. It detects only toxin B because this is the only cytotoxic. It needs technical expertise and long turnaround time. And this is not routinely used already and not recommended to use it. We can use this ELISA. It's very important to be used. And we'll see when to use every test. When we go to this one, this is one of the bacterial antigens, glutamate dehydrogenase. It's available in the Mustashfa 57 available, both glutamate dehydrogenase, ELISA for toxin A and B, and PCR available also. And BioFire available everywhere. Glutamate dehydrogenase, it's low sensitivity. But when you combine to this and that, toxin A and B plus the glutamate dehydrogenase, it reached almost 95% sensitivity. It's easy job, easy to test, quick turnaround time, but it needs confirmatory test. It will not tell you this is toxin producing or not toxin producing. This is called glutamate dehydrogenase. What about the PCR? PCR sensitive, in the highest sensitivity, the PCR, but the specificity almost 100%, easy to check, quick turnaround time, but number one, expensive. This is number one, it's more expensive. It can detect the bacterial gene toxin, but sometimes it can be positive in absence of toxin secretion. This is another issue for the PCR. The culture, anaerobic culture, at the start we said this is an anaerobic organism. The culture fructose agar, it is, yes, it is highly sensitive and specific, but the problem is labor intensive, long turnaround. You will wait for 3-4 days. cannot differentiate between toxin and non-toxin producing organism. It will tell you this is C. difficile. Is it toxin, not toxin? For that, the culture is not used nowadays. There is test nowadays available called Tricore. Tricore, it's containing glutamate dehydrogenase plus toxin A and B. They are doing this both together. If both are negative, this is sure C. difficile negative. If both glutamate dehydrogenase and toxin A and B negative, positive, this is sure positive test. If the discordant result, one positive and one negative, you should do PCR to diagnose. What is the statement of the IDSA saying about the diagnosis? There is another marker of disease has been stated in the IDSA guidelines, like lactoferrin. Lactoferrin is iron binding glycoprotein found in neutrophils. Concentration in the stools proportional to the neutrophil count, still non-specific. Calprotectin, all of you know the calprotectin in inflammatory bowel disease. It is a calcium binding protein found in the neutrophil cytosol. Also the intestinal cytokines, that IL-8, interleukin-1 beta, has been evaluated. But the statement of IDSA, it's nocive list, using this one in the diagnosis is not established. We should not use all these markers to diagnose active disease or inactive disease. The statement which is there in IDSA guidelines, how to test. Number one, they put the quality of the sample. You should have at least diarrhea, liquid stools, more than 3 bowel movement in 24 hours, unformed stools, new onset, not induced by laxative, very important item. If your lab having this diagnosis and you agree for the lab on this one, you can use the PCR alone for diagnosis. It's been stated like this. Either you can use the PCR or gene expert to diagnose, or stool toxin as a part of multi-step, as we'll see now. If your lab is not agree 100% on this one and no criteria on the hospital, you should do this multi-step diagnosis. What is multi-step diagnosis? Patient with more than 3 times of liquid stools, you do glutamine dehydrogenase, okay, plus toxin A and B. If both are positive, this is confirmed. If both are negative, this is lack toxin difficile, negative for toxin C. difficile colitis. And this, if both one negative and one positive, this is discordant result. You go for PCR. If PCR is positive, 100% choose this positive. If it is negative, this is already negative. What about children and infants? C. difficile is very rare in the infants less than 12 months. There has been said, number one, the receptor for the disease is less well developed in infants. Number two, they have already antibodies from the mother. But there is very high rate of colonization with C. difficile. For that, IDSA statement for infants should never be routinely recommended to screen neonates less than 12 months of age with diarrhea. Look for another etiology. If you didn't find, you can screen. And I went through articles diagnosing C. difficile colitis in neonates. They did everything before, cultures and everything, and rotavirus, all negative, they went for this one. But the IDSA guidelines is against routine testing of the C. difficile in infants less than 1 year. Now we are going to the most important item of our lecture today, the treatment. What to treat, when to treat, this is very, very important. Number one, this is the inciting antibiotics or incriminated antibiotics which cause the problem. Supportive care, correct the fluids and the electrolyte imbalance. Low residue diet, as tolerated, to reduce the stool frequency. Please don't use Imodium or loperamide. It can lead the patient to go into severe ileus. There is something called empiric treatment also had been said in IDSA guidelines. Patient critical and severe or fulminant colitis, don't wait for the diagnosis. If you suspect, start empiric treatment till you have a definite diagnosis. And treatment is not indicated in patients who have positive diagnostic lab, but no diarrhea. So if patient came to you, I did my stool sample, was positive C. difficile, whatever toxin, and the patient having no symptoms, don't start any treatment. Please don't use intravenous vancomycin whatsoever. Intravenous vancomycin has no effect on C. difficile colitis. Vancomycin is not excreted in the colon. If you go from my lecture by this one single slide, this is enough for you. The classification before was mild, moderate, severe, complicated. It was complicated classification. But nowadays, IDSA make our life very easy. Initial episode, non-severe, or severe, or fulminant. They put this one instead of the severe complicated. If you have initial episode, non-severe, mild attacks of C. difficile colitis, this criteria, WBC is less than 15 and creatinine less than 1.5. What to do and what is the change from the previous guidelines? They recommended only 2 antibiotics, vancomycin, 125 milligram 4 times a day for 10 days. Strong recommendations. Or fidaxomicin. I'm using fidaxomicin in few of my patients. 200 milligram BID for 10 days. Strong recommendations. But they said this is very important, this recommendation alternative. If these both agents are not available, vanco and fidaxomicin, metronidazole 500 milligram TID orally for 10 days. This is weak recommendation. And we'll see now the studies supporting the IDSA guidelines for these items. And it has been said in the guidelines, you can extend the treatment up to 14 days if the patient is still symptomatic. This is for one issue, the yellow one, this is the initial episode, non-severe cases. If you have initial episode severe case, WBC is more than 15,000, creatinine more than 1.5, you can start by vancomycin, 125 milligram, 4 times a day for 10 days, or fidaxomicin. There is no metronidazole here whatsoever, and we'll see now by trials why this recommendation. If the patient coming to you initially with fulminant C. difficile colitis, hypotension, shock, ileus, toxic megacolon, you can give vancomycin 500 milligram 4 times a day, either by mouth or NGT, strong in recommendations. Or if the patient having ileus, you can add rectal instillation of vancomycin. You put the 500 milligram of vancomycin on 100 ml of normal saline and put a rectal retention enema, put a Foley cath in the rectum, inflate the Foley cath, keep it as possible as you can this one, and repeat it 4 times a day or every 6 hours. This is very important. Here you can use intravenous metronidazole. It can be secreted in the colon. 500 milligram every 8 hours. A strong indication in the fulminant cases should be added to the oral and rectal vancomycin, particularly if ileus is present. Again, mild disease, I'm repeating because this is the most important slide. Mild disease with less number of white cells and normal creatinine, vanco or fidaxomicin. Here, the first time in the guideline to say the recommendation for metronidazole is very weak. This is the priorities. Initial severe, either vanco or fidaxomicin. Initial fulminant, vanco 500 4 times a day, PO or NGT, and sometimes you can use it rectal, as we said how to use it rectally, and plus IV metronidazole. For children, the IDSA guidelines said either metronidazole or vanco can be used for non-severe children. What is the support of what they did for this IDSA guidelines? This article has been mentioned in the guidelines. This study, they compared between vanco and metronidazole for the mild and severe cases. What they found, this study on 172 cases, in the mild disease, no statistically significant difference between the vanco and metronidazole. But when we go for the severe disease, you will found statistically significant difference between the vanco and the metronidazole. 97% recovery rate for vanco and only 70% for metronidazole. For that, metronidazole had been removed from the severe cases. Another study, very important on big number of patients, 1,118. This is the pooled analysis between all the type of patients. The statistically significant difference between the vanco and metronidazole. For metronidazole, only 70% and 81% for vanco. What about the difference between fidaxomicin and vancomycin? Do we have trials comparing? Big trial on 600 patients showing the initial response, recurrence, and sustained response. The most important in this study is this item. The recurrence rate for fidaxomicin is statistically significant, less than the vanco. For that, I used fidaxomicin in these cases. Patients with recurrent cases and severe problem with the difficile colitis, I used fidaxomicin. I have found one patient who had 3 attacks of difficile colitis with vancomycin treated, and the 4th attack patient was resistant and responded very nicely with fidaxomicin. Another article of the pattern of the number of recurrence, number of the patients with recurrence, the recurrence is less with fidaxomicin than the vancomycin. What about the surgical treatment? From the start, if you have severe or fulminant, call the surgeon, put him in situation, put him with you in the picture. I have a case of severe. I'm managing now. I may need you to do something. What's something to be done? ISL subtotal or total, but the IDSA guidelines stated subtotal colectomy to preserve the rectum, to continue the anastomosis later, and to have the patient having continence after. This is strong recommendations to have subtotal colectomy for fulminant cases not responding to the usual measures that has been said. This is for the surgical management. There is another small study on 20 patients published on diverting loop oleostomy. We'll see it now. With colonic lavage, what they are doing for this diverting loop oleostomy, this is the diverting loop oleostomy. They get the ileum loops outside like what you are seeing now. This is the antegrade, this is the retrograde. This is the antegrade. Will push here the vancomycin to go to direct to the colon. It will rest the colon. Not only that, they are pushing 8 liters of polyethylene glycol and nutrition and all this plus the vancomycin, and the patient sometimes respond very nicely and very good response to this diverting loop ileostomy. If there is another something to be done also to help the patients, if the patient is very critical, we did this once in life has been done. This very important issue to do can be done by the interventional radiologist. Just cecostomy tube guided by fluoroscopy. They go to the cecum and they put inside these tubes of gastrostomy. They inflate the tube inside and they start doing the same by doing the ileostomy. The same has been done, and to put the vancomycin inside. Even cecostomy can be done surgically. So this is called cecostomy tube insertion. It saved the life of this 75-year-old patient in this article. He was patient of solid organ transplant. He was shocked and in morbidly ill case. They put the cecostomy tube, even he was in dialysis, and the patient recovered fully after putting the cecostomy tube. So we have something else to do with the patients, not only present sometimes in the guidelines. We'll go again back to the guidelines. IDSA guidelines for the first recurrence. Now the patient recovered completely, and then the patient recurred again. If this patient having metronidazole in the first initial therapy, you can treat him for the first recurrence with vancomycin 125 QID for 10 days, up to 14 days. If the initial therapy patient treated with vancomycin, you can use either fidaxomicin or vancomycin. Fidaxomicin again is 200 milligram. Again, it's called Difficile tablets, 200 milligram BID for 10 days, or vancomycin tapered and pulsed dose. How this tapered and pulsed dose, you should know it very well by heart. 125 milligram 4 times a day for 2 weeks, BID for 1 week, OD for 1 week, every other day for 2 to 8 weeks. It's called tapered and pulsed dose. This is the first recurrence. Tapered and pulsed dose vancomycin. If the patient having multiple recurrence, not only one single recurrence, what are the options for treatment? Number 1, vancomycin tapered and pulsed. No, now you know what is tapered and pulsed. The vanco, 125 4 times a day for 2 weeks, BID 1 week, OD 1 week, and then every other day for 2 to 8 weeks. This is the tapered and pulsed dose vancomycin. The second option for treatment of these recurrent episodes, vancomycin rifaximin plus rifaximin. First, vancomycin 125 4 times a day for 10 days, After these 10 days, you start rifaximin 400 milligram TID for 3 weeks. This is one of the options for the recurrent C. difficile. Fidaxomicin also has been done as option for the treatment of the recurrent Clostridioides difficile. And here, the option of fecal microbiota, will have some details of this fecal microbiota. I will give, inshallah, a special lecture for the C. difficile in inflammatory bowel disease. But one of the most important and first recommendation for the American Gastrointestinal Association for the C. difficile in inflammatory bowel disease, number 1, clinician should test the patient with flare, any coming flare, for underlying C. difficile colitis. And this already flow chart, very important. I'll see in my lecture later for the C. difficile in inflammatory bowel disease. Very, very important approach for these cases. When to go for the immunosuppression, when to stop immunosuppression, when to start the antibiotics for the C. difficile, when to continue for the TNF blockers, and all these items in inflammatory bowel disease, not our issue for today. Do we have other options for treatment? Yes. This is already reports and some meta-analysis, but this is not IDSA guidelines. I'm stressing, this is not an IDSA guidelines. IVIG, few articles reporting the use of IVIG, probiotics, but later it has been disputed the effect of IVIG and is not recommended to give it. Probiotics, shall I give patients probiotics during the acute attacks? No recommendation. Shall I give probiotics for prevention? If I start antibiotics, to give patients some probiotics to prevent C. difficile colitis? No recommendations. We said already rifaximins sometimes can be used for the recurrent cases after the vancomycin. Nitazoxamide, there is some trials I will see later. There is resin, anion binding resins called tolivamir. There is article comparing tolivamir to vancomycin to metronidazole, and tolivamir is a failure. It was before suspected that it can be used, but later not to be used. What about tigecycline? And this new molecule, this is ridinilazole. Ridinilazole, this one is an oral medication we'll see now. For the tigecycline, this is the first article reporting about tigecycline for treatment of severe complicated C. difficile, and this is the recommendation of that article. Tigecycline appeared to be a reasonable addition to the therapeutic regimen of severe and complicated C. difficile. Me, myself, I have used in one case in Egypt and 2 cases here in Saudi Arabia. One of the patients was in a big hospital in Cairo, she was intolerant to both metronidazole and vancomycin and don't have any options. No fidaxomicin in Egypt. I used the tigecycline for 10 days, excellent response, 100 milligram loading, followed by 50 milligram twice a day. There is another article of meta-analysis of 6 studies, and the comment of this article, available evidence suggests that tigecycline may be considered as a potential therapeutic option for patients with severe C. difficile, and especially in severe cases, not in the mild cases. Nitazoxamide has been used and demonstrated in a small number of cases, of 35 cases, but who failed the patient metronidazole. They found good response with nitazoxamide. Rifaximin, as we said before, can be used in relapsing patients after use of the vancomycin in the patients with multiple relapses. What about the monoclonal antibodies? In the New England Journal of Medicine, there was a big article on the use of monoclonal antibody against toxin A and toxin B. Did it differ? It reduces the recurrence. I'm not talking about dealing with the cases of the actual infection now, but it reduced the recurrence rate. There is something called bislotoximab, monoclonal antibody binding toxin B. It received the approval, FDA approval in 2016, and probably in the next guidelines, when it appears, it will appear in the next IDSA guidelines. They did a randomized control trial for either bislotoximab or toxin A or toxin B. Very important study called Modify A and Modify 1 and 2 study. This found this green column is the very important column. This one containing bezlotuximab, which is the monoclonal antibody against toxin B, and actuximab, this actuximab, the monoclonal antibody against toxin A. And when they use the toxin A and toxin B monoclonal antibody, the recurrence rate is very, very low, less than 15%. And the era will be later for the appearing for the data of the monoclonal antibody of the toxin A and B. What about the fecal transplantation? Is it so easy to give a fecal transplantation to patient like this, get a small amount of normal stool and give it to him? No. It needs special regulations, special indications. Rationale here, restoring the bacterial homeostasis. It delivered either by nasogastric tube, oral capsules, or colonoscopic delivery. All the three routes has been used. And one of the patients of the 16 survivor has seen subsequent recurrence, and the recurrence was very, very rare with the fecal transplantation. Not only used in C. difficile colitis, many indications, including inflammatory bowel disease, irritable bowel syndrome, has been used in many indications, this fecal microbiota transplantation. The donor, what to do for the donor? The C. difficile toxin or C. difficile by PCR, and doing also bacterial culture, fecal giardia. There is very important item said to me by Dr. Mervat Anani from Mustashfa 57. Sometimes they had the false positive testing for the cases of the C. difficile and in their lab by Giardia antigen, and she doesn't know what is the explanation that Giardia antigen can intermix with this C. difficile colitis diagnosis. Fecal cryptosporidia antigen should be done for that donor stool. Ova and parasite, H. pylori fecal antigen should be done also for these cases. Serology should be done for the donor. HIV, all type of hepatitis A, B, and C. Also syphilis, RBR, should be done to rule out any infection to be transferred to the patient by this one. What about the rule of the BBI? Should we stop BBI? IDSA statement about the BBI is insufficient evidence for discontinuation of BBI as a measure of preventing Clostridium difficile. But they said in the same time, if the patient not needed, indicated, strongly indicated to have BBI, you should stop it for that suspicion of association between the BBI and C. difficile colitis. There are insufficient data for the time being to administer probiotics for primary prevention of C. difficile outside the clinical trial. No recommendation to give probiotics for the cases of C. difficile colitis. We are going now to the last part, the infection control. What we are doing. The surveillance data, this is by the IDSA, they classified the type of the disease, because when you notify, you should know what you notify, what type of infection. Is it healthcare or healthcare facility associated onset? That's to say, more than 48 hours after the third day of admission, that is number one, or community onset, healthcare associated. What is this? Patient was in the hospital and is discharged from the hospital. Less than 4 weeks from discharge, this is called community onset healthcare associated. There is another type, which is community associated C. difficile onset in the community with more than 12 weeks post discharge. This is called community associated C. difficile according to the IDSA. I made it for you in a very easy draw. This is after more than 2 days after admission, after 3 days admission. Having C. difficile, this is called healthcare or hospital onset C. difficile. After less than 4 weeks of discharge, this is community associated, community acquired healthcare associated. More than 12 weeks, this is called community acquired C. difficile colitis. And when the people doing the infection control, and thanks for the infection control people in Arfan Bagedi Hospital who supply me with that, some of the data, they express the rate of healthcare associated by number of cases per 10,000 patient days. This is the recommendation from the IDSA. And to express the community acquired healthcare associated prevalence rate as number of patients per 1,000 patient admissions before. This is from my hospital I'm working now, Arfan Bagedo Hospital. Number of cases in the last 5 years, it was 2 cases, 5 cases. When orientation started here, 27, 50 patients per year, 25 cases in the last year in 2020. And this is, we did it already by quarterly to know what is the problem, when was the antibiotic abuse. And this is one of the very important for the people working in the stewardship program. This is one of the important items for the stewardship program. If you have good stewardship program, stewardship program, you will have declining rate of C. difficile, and this is one of the criteria of improving C. difficile. And there is new recommendations in the last year to do something called SIR, or standardized infection rate. Standardized infection rate, our target will be, we are relaying to the observed items to the expected. We are predicting to have certain item, and they expect what happened already another item. Both, if you more than one, we have high infection or standardized infection ratio. This is not recommendation by the IDSA, but recommendation by another facility in Europe. Shall we do alcohol or hand hygiene for every one single patient? This is very important issue for the IDSA. Alcohol-based gel can be effective in routine or endemic settings. But if you have an outbreak or hyper-endemic situation, increasing number of patients, all the visitors and healthcare should do hand wash with soap and water before and after caring of the patients. And so in regular conditions, very low number of patients, you can use the hand hygiene by alcohol without water and soap. But you have an outbreak in your hospital or hyper-endemic situation, you should do soap and water before and after caring. Not only that, in the regular situation, if no hyper-endemic or no outbreak, and you are dealing with the stool of the patient or fecal contamination is likely, you should do the hand wash with the water and soap. It's better to use disposable patient equipment when, if possible, or even you can reusable instruments which can be cleaned. And sometimes you are using the special stethoscope for that room, not to be transferred to other patients. Where to isolate the patient? What is the precaution to be used? Patient should be isolated in a private room, and sometimes you can cohort what 2 patients with C. difficile can be in the same room, but don't cohort with patients with different infections, that MRSA and C. difficile. No, VRA and C. difficile cannot be. Cohort the patient with C. difficile in the same room. Some preemptive isolation, that's to say, if you suspect patient antibiotics having frequent diarrhea, not yet diagnosed, and you suspect, keep the patient isolated till you are definite. Contact isolation is very important with gloves and gowns, direct contact with the patient. DC isolation, when to DC isolation? This is one of the very important items. When to discontinue isolation. 48 hours after the diarrhea resolved. Don't wait for the stool toxin to be negative. There is no test of cure. This is very important from the IDSA. Don't do test of cure. Once 48 hours, no more diarrhea, you can remove the isolation and keep the patient remove the isolation from the patient at that time. What about terminal cleaning? This is in IDSA also. Terminal cleaning or deep cleaning of the room with the spirocidal agent should be considered during endemic high rates or outbreaks. If you have very high rate outbreak, or if there is evidence of repeated cases in the same room, many cases come to the same room, and having this one, you should have terminal cleaning and deep cleaning with spirocidal agent, very important. There's limited data to recommend automated or terminal disinfection by the automated, there is no recommendation to use it nowadays for every room cleaning. Daily cleaning with sporicidal outbreaks or hyperendemic areas is very important. Antimicrobial restriction is very important. Stewardship program. Any hospital should have a stewardship program. I was the head of this stewardship program for almost 11 years. We are suffering too much for the abuse of antibiotics. we should decrease the duration of exposure, number of antibiotics, IVPO shift, also the de-escalation and decreasing the spectrum. All these items are very important. Best evidence for controlling the difficile demonstrated with restriction. If you have high outbreak or high number of cases of difficile in the hospital, at that time we restricted the quinolone, cephalosporin, and the clindamycin. All these should be restricted by the IDSA guidelines recommendations. Any news about vaccine? This data, I got it already on January 14, 2021, about the Clostridium difficile vaccine efficacy trial. There is ongoing trial now for patients more than 50 years of age. They are recruiting cases. It will be the result available by June 2021. In short, I'm summarizing what I said. We are increasing in incidence, severity, and poor outcome. We have sometimes something called hyper-virulent strain that has been already available in United States, North America, and South America, and Europe. A lot of cases before, in the 2004. We have the lab diagnosis, challenging. We are see the options already, either to look for the toxin or to look for the organism, and something called multi-step therapy, multi-step diagnosis. The multi-step we have in Egypt already, the glutamate dehydrogenase. We have already in Egypt the toxin A and B by ELISA. We have already the PCR or gene expert diagnosis by PCR, and BioFire also can diagnose it. No reasonable explanation for treatment failure. Sometimes we have a case of treatment and mortalities till now. Community infection-based infection are not well understood, and we should look for these cases of community-acquired infection. Improved treatment also are needed. It's extremely important to accurately detect and diagnose and treat these cases. And already, I'm summarizing the treatment. You should classify the patient, either mild disease or severe or fulminant. Mild disease, either vanco or fidaxomicin. If not available, you can use metronidazole. Severe disease, either fidaxomicin or vanco or fidaxomicin. In the fulminant cases, you have the option of high dose vancomycin of 500 milligram 4 times daily. Sometimes you can use rectal retention enema with vancomycin 4 times a day, plus the IV metronidazole. And we have another options of the tigecycline and other options. And thank you. Any questions? Any questions? دكتور مصطفى معانا؟
ايوه انا مع حضرتك. انا في ناس اهو عايزه تسال. دكتور فيصل حميده.
السلام عليكم.
دكتور فيصل، ازي حضرتك؟ اخبارك ايه؟
ازيك يا فندم؟ ازيك يا دكتور احمد؟
عامل ايه؟
محاضره طبعا جميله جدا از يوجوال. طبعا انا بس ليا سؤالين. اول سؤال، لو مريض مثلا متنوم معايا ولسه في بدايه الادميشن ومثلا عنده سيفير سيلولايتس ومحتاج انه يكمل على الانتي بايوتيك بتاع السيلولايتس مثلا، واكتشفنا ان عنده سيمتوم وعنده كوليستريديوم انفكشن، هنعمل ايه بالنسبه للانتي بايوتيك لو مش هقدر اوقفه اللي هو الاوفندنج انتي بايوتيك؟ ده اول سؤال. السؤال الثاني، انا شخصيا كان معايا مريضه هنا في الوورد كان عندها توكسيك ميجا كولون نتيجه ريبيتد كوليستريديوم.
انت فين في يوكي؟ انت فين في يوكي يا دكتور فيصل؟
انا في فريملي في غرب لندن.
نعم.
كانت مريضه عندها توكسيك ميجا كولون نتيجه ريبيتد كوليستريديوم، فكنت بسال هل في رول لبروفلاكتيك انتي بايوتيك؟ كنا ماشيين على فيدوكسامايسين، هل في رول لبروفلاكتيك انتي بايوتيك زي بروفلاكتيك فانكومايسين مثلا از لونج تيرم تو بريفنت فيرذر؟
والله سؤالك يا دكتور فيصل دايما من ساعه ما كنت معانا وانت دايما تسال الاسئله التريكي الممتازه اللي فيها اتقال فيها يعني محاضرات. اللي انت بتقوله ده اتقال فيه محاضرات. الاي دي اس اي جايد لاينز وعلى الاب تو ديت موجود الكلام اللي بقوله ده، ان انت you need the antibiotics in a critically ill patient. You can continue but minimize the spectrum that you want. That's to say, you want, and if you have a patient with the severe cellulitis, tigecycline can combat for both the C. difficile and the colitis, the cellulitis in the same time. So if you need the antibiotic, continue the antibiotics. Don't stop and continue the management, because you cannot stop the antibiotics in a critically ill patient and you are saying I'm managing C. difficile colitis. You will kill the patient from the other way. So you continue. The other question, this patient had C. difficile colitis and now recovered completely. I want to give him antibiotics. Any recommendation to give prophylactic vanco by the IDSA guidelines? You want to ask me? No, don't give. Continue, and if your patient symptomatic, start. But there is another issue for this one, and even available and up to date. If the patient is critically ill and having repeated attacks of C. difficile colitis, you can give him vancomycin 125 milligram twice a day for the period of antibiotic given to him. This is not IDSA guidelines, but you are asking this one because it had not been mentioned clearly in the IDSA guidelines. But thanks always to Dr. فيصل دايما بتسأل الحاجات المهمة.
هل في أي أسئلة تانية؟
Stop the TNF blocker, keep the steroids to the minimal to be used for the steroids, and give the full course of treatment for the, but they are recommending don't use even the IDSA guidelines. Don't use metronidazole in patients with inflammatory bowel disease and acute attacks of C. difficile colitis. Don't use it. If you want to use, you can use the either vancomycin or fidaxomicin. There is no recommendation to use the metronidazole in patients with C. difficile colitis in association with inflammatory bowel disease. Any other questions? حد عايز في أي أسئلة؟ دكتور مصطفى.
أيوة دكتور أحمد، اتفضل.
في ليك كومنت أو سؤال يا دكتور مصطفى أو حاجة؟
في سؤال اهو اتسأل على الشات. دكتور محمود الزهيري بيسأل how long we need to isolate patient with C. diff?
To isolate patient with C. diff, once the patient continuously diarrhea, keep him isolated till 2 days after stoppage of diarrhea. That's to say the patient admitted now. You start the treatment. 3 days, after 3 days, the patient asymptomatic. Wait for 2 days more and then remove the isolation. Don't wait for test of cure. There is no test of cure for the C. difficile. Continue your 10 days, but the isolation should be left 2 hours after being asymptomatic. وشكرا على حضورك يا دكتور محمود معانا، وشكرا لكل الحضور اللي ادونا يعني ساعة من وقتهم. نشكرهم جدا على تشريفهم لينا. في سؤال تاني يا دكتور مصطفى؟
أنا مش شايف أسئلة. دكتور أحمد مبارك، اتفضل يا دكتور. في دكتور كمان طارق زاهر بيسأل prevalence of C. diff في السعودية أو إيجيبت.
والله في ايجيبت انا حاولت ادور. هو طبعا في الستيتس زي ما قلت لكم 500,000 كيس بير يير، انه عندهم يعني statistics can make it all over the country. It's very easy. في الالكترونيك ميديكال ريكوردز it's easy job to do it. لكن كل المنشور في مصر او في السعوديه بيبرز على few cases number، مش معمول حاجه نيشن وايد. لا في مصر ولا في السعوديه معمول حاجه نيشن وايد للاسف.
الجنسيات بتاع العيانين اللي حضرتك شفتها في السعوديه كانت ايه؟
نعم؟
جنسيات العيانين اللي جالهم سي ديف.
اللي جالهم سي ديف عندي فلسطينيان اللي هي استخدمت معاها الفانكومايسين دي قريب. عندي سعودي يعني almost more than 70%. انا في السعوديه يعني more than 70% سعودي. نون سعودي شفت ايجيبشنز، شفت برضو سيريان وفلسطينيان وليبانيز، بس الموستلي كان سعودي.
في مصر شفت كام حاله؟
مصر شفت يمكن وانا هناك، انا اشتغلت اكشوال بعد الدكتوراه، هم 3 سنين اللي شفتهم ما شفتش تقريبا حوالي 10 حالات تقريبا. اي دونت نو ده اندر ريبورتنج ولا ده انسيدنس قليل في مصر ولا ده يعني هل التيست كان ايه. انا باي ذا واي وانا شغال هناك في مصر وان اوف ذا في اي بيز، والسواق بتاعه راح 3 معامل كبيره مش عايز اقول اسمائها يعني، 3 معامل كبيره كلهم تعرفوها. انفورشنتلي الكلام ده مش من 100 سنه، السنه ده الكلام ده من 2014 يعني من 7 سنين. راحت 3 معامل there is no difficile toxin and no NATS diagnosis of this one. عيانين كان عندي في الفرنساوي I tried to look for difficile toxin unfortunately ما يعني قالوا لي ما فيش، ودور في معامل ثانيه، وانفورشنتلي عالجت ناس امبيريكال. ف do we have under reporting under diagnosis؟ فمش عارف، لان انا حاولت اعمل كده واشوف عيانين واحاول ادايجنوز، unfortunately ما لقيتش معمل يسبورت مي بقوه. لكن لما كلمت النهارده الدكتوره ميرفت عنان بصراحه حقيقي يعني كانت قالت لي ال3 دايجنوزز ار افيلبل في معهد الاورام، وقالت لي على حكايه برضه الفولس بوزيتيف تيستنج مع الجيارديا ومع الانتيروكوكاي. قالت لي كده مع الجيارديا والانتيروكوكاي sometimes I find false positive testing of C. difficile toxin. ودي كانت حاجه غريبه جدا، هي مستغرباها حتى نو اتيولوجي مش مكتوب حتى في الليتريتشر. لكن عندهم في 57 في البايو فاير في جين اكسبرت فور دايجنوزس ناتس، في الجلوتاميد دي هيدروجينيز، في الايزا توكسين اي اند بي. واعتقد ان في معامل كتير في مصر فيها التوكسين اي اند بي دلوقتي ناو دايز، وفيها الجلوتاميد دي هيدروجينيز، والناتس طبعا موجود. دكتور مصطفى اكيد عارف البايو فاير في اي اماكن في مصر يعني.
في اي حد من الدكاتره يحب يسال اي اسئله تاني؟ دكتور عاطف بيسال from your experience initial episode mild would you prefer to start with metronidazole or vancomycin؟
الجايد لاينز قالتها رسمي، قالتها رسمي. انا واحد بني ادم عندي فانكومايسين ريدلي افيلابل وعندي فيداكسومايسين ريدلي افيلابل، والترايلز قالت لي ان الفانكومايسين سوبيريور على الميتريندازول والفيداكسومايسين سوبيريور على الفانكومايسين. انا لو عندي ما فيش فاينانشال ايشو ممكن استخدم ايسر. طبعا سمور تشيب ان انا استخدم فانكو، لكن الفيداكسومايسين موجود. يبقى اذا فيرست ابيسود مايلد استخدم فانكومايسين 125 مللي جرام، وفي منه كبسولز على فكره. حد من زمايلنا الافاضل من اساتذتي اللي كان بيبعت لي عيانين كبسولز فانكومايسين كبسول من اوكي. في ساعتها الفيرست لاين في النون سيفير فانكومايسين، الالترناتيف الثاني فيداكسومايسين لو افيلابل ومش هو فيري اكسبنسيف، بيتكلف في اليوم حوالي تقريبا $2000 الفيداكسومايسين، او يا رب في 3 ايام $2000 يعني كل كورس هيحكي لي حوالي $5000. اللي يبقى اذا عندنا الاوبشن فانكو او فيداكسومايسين if not available، او في financial issue في المايلد ديزيز you can use the metronidazole.
هو الفكره بس ان الفانكومايسين هيكلف العيان حوالي 700 جنيه، لكن الفلاجيل هيكلف العيان حوالي 10 جنيه. وكان
ما هو عشان كده في ساعه اهو موجوده، اهو في ساعه موجوده هي موجوده بتقول لك ما هو عدم وجوده برضه فاينانشال. في معاه واحد ما معهوش فلوس تستخدم، خلاص ما انت عندك الاوبشن اديله في الميترونيدازول. هم دايما الاي دي اس اي قالوها حوالي 30 مره، وكاتبين كمان في الاب تو ديت الكلام ده for fear of the neurotoxicity by the or peripheral neuritis by metronidazole.
في سؤال من دكتور وحيد is recurrence due to antibiotics use or without؟
في سؤال تاني؟
is recurrence due to antibiotic use or without؟
Recurrence can be either with or without antibiotic use. Can be either both. Sometimes recurrence of the same organism for the same patient, and the first organism has been with the same type, or reinfection already with another C. difficile, with or without antibiotics, sometimes with chemotherapy, sometimes with renal failure, sometimes with the, as we said before in the slide about the different predisposing factors, with or without antibiotics can occur. تمام دكتور مصطفى؟
تمام. في اي حد من الزملاء عنده اي سؤال؟ دكتور خالد الحربي بيسأل if vancomycin capsule not available how to deal with the vancomycin oral.
ده مكتوبه في الاي دي اس اي جايد لاينز وموجوده في الاب تو ديت. Get the vial of vancomycin. Get the vial. The vial containing 500 milligram. Put it in a 20 ml of sterile water, and then dilute it, and then gave it 125 liquid, 125 of this the solution that you have made already from the vial. You can use it without the capsules. But please, nobody to use the IV vancomycin in treatment of C. difficile colitis. Cannot be used like this. Cannot be excreted in the colon.
هل في أي أسئلة تانية يا دكاترة؟
في سؤال، في أي كومنت من عندك يا دكتور مصطفى؟
لا مفيش أي حاجة يا دكتور أحمد، تحت أمرك، ألف شكر، ربنا يخليك.
تحب تضيف حاجة على اللي قلناه بالنسبة للجايد لاينز؟
لا خلاص، ما احنا قلنا الاي دي اس اي جايد لاينز وقلنا الريكومنديشن. النقطه بتاعت الفلاجيل في دكاتره كتير اثروها. هو كان الديبيت لما الجايد لاينز دي نزلت كان ان هي قالوا يعني الخناقه كانت انها دريفن باي فارما كومبانيز علشان الفيداكسومايسين ان الفلاجيل افكتيف، وفي كذا بيبر نزلت بعد الجايد لاينز عشان تؤيد الفلاجيل وتقول ان انتوا ما ينفعش ان انتوا تخرجوه كده بره الجايد لاينز، الفلاجيل افكتيف. وفعلا جابوا داتا من الفي اي علشان خاطر الافيكاسي بتاع المترونيدازول. انا يعني اظن ان احنا لو في المستشفى جالنا عيان سسبكتد سي ديف او بروفن سي ديف هندي اورال فانكومايسين. لكن لو عيان في البيت والسعر بتاع الفانكومايسين مش هيقدر عليه، ممكن نستعمل الفلاجيل طالما حاله في البيت. انت الفكره بس ان كل الزملاء يبقوا عارفين ان انت لو مش هتشخص السي ديف على الاقل تسسبكت. يعني انت لو ما عندكش القدره ان انت تعمل التحليل لانه غالي او مش متوفر او انت في مستشفى ما فيهاش الامكانيات، ساعتها انت once you suspect سي ديف زي ما حضرتك قلت في الجايد لاينز start treatment. وفي دلوقتي ريكومنديشنز حتى في عيانين الترانسبلانت زي بتوع البون مارو ترانسبلانت ان هو ان احنا ندي اورال فانكومايسين بروفيلاكتيكلي. يبقى العيانين بتوع ترانسبلانت اللي هم اكسبكتد ان هم ياخدوا انتي بايوتكس بديهم فانكومايسين بروفيلاكتيكلي. لكن سبحان الله السي ديف قليله جدا 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 في الدول العربيه، وحتى في الدول النباتيه زي الهند كان قليل فيها السي ديف. السبب مش معروف لكن دي مشهوره. السي ديف في امريكا مش زي السي ديف في مصر خالص. في امريكا كان المستشفى عندنا ممكن تجي لك 10 حالات مثلا في اليوم، فيعني قول 3000 حاله في السنه. لكن انت هنا في مصر دي اللي بيخلي الدكاتره يدوا انتي بايوتكس على راحتهم. لكن في امريكا كان هو ده اللي دايما بيوقف الناس عن اعطاء اي دواء، لان كان اول ما يدي دواء زياده ملوش لازمه تلاقي العين جاله سي ديف وابتدى يفيص. فهي دي يمكن
دكتور مصطفى خلي بالك ان انت الفلاجيل، انت بتروح اي صيدليه تاخد لك 5 6 علب فلاجيل في مصر او في البلاد العربيه. السعوديه لغايه النهارده ريستريكتنج كل الانتيبيوتكس كلها بلا استثناء ابارت فروم فلاجيل او السكنيدازول او التينيدازول. دول مش ريستريكتد لغايه النهارده في السعوديه. فاللي بيجي له اتاك اوف دايريا سواء كان وات ايفر بقى بيشنت على انتيبيوتكس مش على انتيبيوتكس ممكن يروح الصيدليه ياخد. دي مشكله. هل دي مشكله عندنا في بلادنا عشان ما هياش سترونج ستيورشيب بروجرامز ولا لا؟ دي برضو حاجه من الايشو. على فكره باي ذا واي الاكمت جايد لاينز طلعت بعد الاي دي اس اي ولسه حاطه لغايه النهارده المترونيدازول في المايل ديزيز لغايه النهارده. وفي
هو بسبب
برضه
الحكايه دي.
نعم،
بسبب حكايه ان هم كانوا بيقولوا انها اتس فارما دريفن جايد لاين.
تمام. دكتور احمد سعد كان رافع ايده وعايز يتكلم.
اتفضل حضرتك يا دكتور احمد.
دكتور احمد سعد. دكتور احمد سعد كان عايز يتكلم. هو فين؟ ما احمد سعد حميات. خلاص مش هتسال يا دكتور احمد؟
ايوه السلام عليكم دكتور احمد، معلش هو كان
عليكم
بس
السلام.
معمول
لا ولا
امرين.
يهمك دكتور احمد، اتفضل.
الف شكر لحضرتك على المحاضره، يعني جزاكم الله خيرا.
وياكم السلام.
كنت عايز اسال بس بالنسبه للسامبل بتاعه الستول، سواء هعمل لها يعني وات ايفر التست اللي هعمله فيه بريبريشن معينه للسامبل، محتاج مثلا فريش سامبل.
انت جيت متاخر شويه. السامبل احنا عملنا لها 2 سلايدز. اول حاجه لازم تكون فريش سامبل less than 2 hours، تتبعتها المعمل. انت اكسبكتنج ان انت مور ذان 2 hours تغطي العينه كويس قوي قوي، وكيب ات ان ريفريجريتور ات 4 ديجري سنتيجريد اب تو 3 دايز. ممكن يتحط في الريفريجريتور عند 4 درجات. نمره بس اول حاجه العيان ما يكونش واخد لاكستيف، دي مهمه قوي، قالوها في IDSA. وقالوا تكون فريش سامبل، وقالوا تكون ليكويد ستول، ما تجيبش هارد ستول تبعته. وقالوا ان انت لو اكتر من 3 ايام وهتبعتها في منطقه ابعد يكون تحفظها اندر ماينس 70.
تمام، الف شكر يا دكتور، جزاكم الله خير.
شكرا جزيلا. شكرا لكم. تمام كده يا دكتور مصطفى؟
تمام يا دكتور احمد، تمام. شكرا
جزيلا لكم جميعا، ويا رب ان شاء الله بس يكون عملنا يعني ايه هايلايتنج كده وشكرا جزيلا للدكتور مصطفى على الايفورت بتاعك، وجزاكم الله خير. شكرا لكم جميعا. سجلتها يا دكتور مصطفى؟
سجلت. تمام.
شكرا جزيلا. السلام عليكم.
عليكم السلام.